Greetings, fellow participants in the International Tuberous Sclerosis Research Conference. I'm Hope Northrup, and I'm the Director of Medical Genetics in the Department of Pediatrics at the McGovern Medical School, University of Texas Health Science Center at Houston. First, I want to start by thanking the organizers for allowing me to be part of the conference. The session that I was assigned is on prevention. And I wanted us to think for a few minutes about what prevention could look like for tuberous sclerosis. And this first slide has the non-clinical features of tuberous sclerosis. And I want you to focus on that second bullet point that states 2/3 of cases are sporadic and 1/3 are inherited. This means that tuberous sclerosis remains in the population primarily because DNA is mutated in the individual who has tuberous sclerosis. The way that DNA mutations occur are shown here. DNA replication errors are mutation of repair during DNA damage. So how common are mutations occurring as we replicate our DNA to pass it on to our children? Well, at 1 in 10 million base pairs, while the replication machinery is moving at a rate of 20 base pairs per second. DNA repair mechanisms luckily catch 99.9% of all errors. This only leaves 0.01% of errors that slip through. But if one of these errors is in a gene, then that can result in a disease in a person. And this is the main way that tuberous sclerosis remains in our population. And right now, we don't have any way to stop mutations from occurring as we pass them on to our children. So the bottom line is that TSC for the foreseeable future is here to stay. So rather than talking about prevention of TSC, I want to pivot to another focus, and that is working towards strategies that prevent bad outcomes in TSC patients. So how can we make this happen? First of all, we need to diagnose tuberous sclerosis as early as possible in life so that we can then intervene. And we need to develop strategies that prevent medical problems associated with TSC from ever occurring. So I think the best way we can start with this early diagnosis is newborn screening. Newborn screening, as you all know, occurs within a few weeks of birth. We currently have newborn screening available for a handful of genetic diseases, mostly enzymatic diseases that are inherited in an autosomal recessive manner. So an important point here is that the current diseases included in newborn screening are very different than tuberous sclerosis. So I think we need to take a step back and talk a little bit about newborn screening. Newborn screening have certain criteria. That is, for the particular disease that we want to be included in newborn screening, we need analytic validity. Analytic validity simply means a rapid economic laboratory test available that will detect an appropriate metabolite. We also need clinical validity. That is, the laboratory test needs to be highly sensitive. We really don't want any false negatives. That is, we don't want to miss anyone in the population who has the disease we are searching for. We need reasonably specific specificity, that is, few false positives, but we can be a little bit less stringent about the specificity. For example, one disease screened for on newborn screening is phenylketonuria, also known as PKU. And in PKU, in newborn screening, 1 out of about 20 newborn screens that indicate the possibility of PKU is truly positive. So 19 out of 20 newborn screens that say maybe the baby has PKU are not true. Those 19 babies don't have PKU. We want a high positive predictive value, as high as we can get. We also want, for newborn screening, clinical utility. And this slide has the 5 bullet points that are considered in clinical utility. First of all, a treatment must be available. Second, early institution of treatment before symptoms show up is important to reduce or prevent the seriousness of the illness. Third, Routine observation and physical exam of the baby won't reveal the disorder. We need a test in order to know. The condition must be frequent and serious enough to justify the expense of screening, so screening must be cost effective. And we need a public health infrastructure in place so that when we get this positive screen back, we can inform the newborn's parents, the physicians who are going to take care of the newborn, and have the ability to have confirmatory diagnostic testing in place so we can then intervene early with treatment and counseling. So newborn screening is based on being proactive rather than reactive. Traditional medicine is reactive. We test for a disease based on signs, symptoms, or family history. In newborn screening, what we do is we try to find people who possibly have a disease before we know any of that. Newborn screening is considered one of the greatest public health triumphs of the 20th century. The rationale is that we are going to prevent devastating effects of treatable diseases. And the poster child for newborn screening is PKU. People who have PKU who are not identified by newborn screening, who were born in the early 1960s or before 1960, have IQs in the 40s. People who are identified by newborn screening with interventions and treatment can have normal IQs and a normal life. In the United States, newborn screening is not federally mandated. Each state decides independently which diseases will be included in newborn screening. And when I got in the newborn screening back in the 1990s, Oklahoma screened only for PKU, while Massachusetts screened for more than 30 disorders. So what this meant is that a baby born in Oklahoma could have a devastating disease and have to present with symptoms of the disease that could lead to severe morbidity or even death. Whereas if that same baby was born in Massachusetts, we could identify that they had that disease before they had a serious episode and treat them prospectively. Well, naturally, parents and individuals like myself in the scientific and medical community advocated that this was not really fair or a good way to have newborn screening programs. So there's been a lot of work toward more uniformity in the United States for newborn screening. And we now have something called the Recommended Uniform Screening Panel, or the RUSP, in the U.S. And it currently includes 61 conditions, 35 are considered core conditions, and 26 are considered secondary. So going back to tuberous sclerosis, one of the first things we need to do is get tuberous sclerosis included on the RUSP in the United States so that we can have screening available. So how does newborn screening currently work? A baby is born, and that baby, usually between 24 and 48 hours of life, before they go home, but after they've been feeding for 24 hours, has a heel stick performed. Their heels are squeezed and blood is put on these filter paper cards. The filter paper cards are sent to the health department where a small punch out from the blood spot undergoes Tandem mass spectrometry. Now, if there are no abnormal metabolites observed, that baby is cleared from newborn screening. If there are abnormal metabolites, each state has a method that the PCP for that baby will be informed, and then the PCPs often reach out to the doctors who are going to help them with determining whether or not the baby truly has the disease. And if the baby truly has the disease, they're going to be followed by specialists. I'm a medical geneticist, and I'm also a biochemical geneticist. So I've been taking care of patients with inborn errors of metabolism my entire career and been involved with newborn screening my entire career. So babies who have positive findings on newborn screening are frequently referred to our center at my medical school. And what we do is we help the PCPs figure out, do the babies have the disease or not, and then we may end up treating them permanently in hand with their PCP. This just shows you a picture of a baby and a blood sample on a Guthrie filter paper. The filter paper where the blood is collected is named a Guthrie filter paper because Robert Guthrie was the individual who designed screening for PKU. And PKU was the first disease that was ever screened for by newborn screening, and this started in most of the US and much of the rest of the developed world in the 1960s. And as I mentioned before, the testing is done through Tandem mass spectrometer. And this is a picture of a Tandem mass spectrometer. We also call it a mass spec. So how does this all work? Well, the way that this works is that we can run this sample through the Tandem mass spec, and we can get the result of many, many different metabolites all at the same time, and we can then look at that result and decide which of these elevated metabolites, if there are any, go with specific biochemical diseases. So this becomes cost effective, even though mass specs are very expensive pieces of equipment, because we can run many tests at one time. So it's cost effective and a very easy way that we can test. And right now, of the diseases on the RUSP, the majority of those diseases are inborn errors of metabolism. So diseases where the baby would come to someone like me to take care of them. So let's look back for a minute at the newborn screening utility, clinical utility that we were talking about before, and think specifically about how that would apply to tuberous sclerosis. Well, first of all, treatment is available for tuberous sclerosis, but right now that treatment is more reactive than proactive. But there are a number of studies all over the world looking at proactive treatments for tuberous sclerosis. So perhaps bullet points 1 and 2 will soon have good data to be able to meet those bullet points for clinical utility for TSC. Routine observation and physical examination of most babies who have tuberous sclerosis will not reveal the diagnosis. A test will be required. I think we can all agree on that. Sometimes we have a very sharp PCP who sees hypopigmented macules and thinks about tuberous sclerosis, but not really very often. Tuberous sclerosis is certainly frequent and serious enough to justify the expense of screening. We just need to make it cost effective. There are diseases on newborn screen now that are only 1 in 100,000 or 1 in 200,000, and as we all know, TSC is 1 in 10,000. And we do have public health infrastructure in place in the United States to be able to add diseases to the RUSP and be able to think about tuberous sclerosis as a candidate. So I'm a geneticist, and you're saying, well, Hope, why aren't you talking about using sequencing for newborn screening of TSC? Well, right now, sequencing is used for one disease as the first-line test for newborn screening, and that's for spinal muscular atrophy. Now, spinal muscular atrophy is different than TSC because it is a recessively inherited disease where the vast majority of patients have the exact same mutation on both copies of the SMN1 gene, making the patients have SMA. And this is a deletion of exon 7. There is sequencing also used for some other diseases on the newborn screen as the secondary part of the screening. So for tuberous sclerosis, we don't have these hot spots like SMA. We currently only have a detection rate of 85 to 90%, and that includes your large deletions and duplications that right now the sequencing methods we're using are not that good at detecting. Then we run into that bugaboo of variants of uncertain significance. The child has a change in TSC1 or TSC2, but we don't know how it affects the protein, and we don't know if it causes the patient to have tuberous sclerosis. And frankly, right now, the cost for sequencing is just too expensive. And then lastly, we have the issue of mosaicism. That is, we have some people who have tuberous sclerosis because they have the change in some cells of their body, but not all, and those are going to be very difficult to pick up on a blood spot. So the TSC Alliance has decided to really make newborn screening a goal and a priority, and I was privileged to participate in the Newborn Screening Summit recently held by the Tuberous Sclerosis Complex Alliance. And the next couple of slides I got from Zoe Fuchs and Steve Roberts at the TSC Alliance. and this summarizes the work they did in the newborn screening workshop I was privileged to be part of last fall. Their goal is stated: they want to be able to screen every child born in the U.S. for TSC using a cheap, effective blood spot test. Research objective: to develop an assay with a funding opportunity. The pie chart shows you who participated: 20 TSC experts, 19 screening experts from various agencies and leading labs, and finally people from some other PAGs, patient advocacy organizations. And this is a list of the participants, and I think you're going to see the names of some people who are participating in this meeting, and names of people that you know from TSC experts, experts in newborn screening, and people from screening, public health, and government agencies. So there were a number of great outcomes from the workshop. First of all, the TSC Alliance is offering a funding opportunity with the goal of an assay that will differentiate between 50% versus 100% TSC1 or TSC2 protein expression in blood spots, to do metabolic profiling of TSC versus controlled newborn blood spots, and other innovative ideas. And they are now rallying the resources to be able to try to make this happen. So now I want to turn to some of the projects that I think are going to help us meet the first two bullet points for clinical utility in newborn screening in tuberous sclerosis. And I'm only highlighting 3 studies. There are many more occurring worldwide, but I'm highlighting 3 studies because our center in Houston is involved in all 3 of these studies. And the first study I want to mention is the PREVENT trial. I'm sure many of you in the audience have been hearing about the PREVENT trial for several years, and we are in the final stages of completing this trial. It is being led by Dr. Martina Beban at the University of Alabama, Birmingham, and her hypothesis is that early identification of EEG biomarkers and early treatment versus delayed treatment with vigabatrin in infants with TSC will have a positive impact on developmental outcomes. And that her hypothesis basically sums up her primary aim. She has a number of secondary aims: to determine the effectiveness of early versus delayed treatment with Vigab on clinical seizure prevention, to determine the impact of early versus late treatment on other components of the Bayley-3, and the Bayley-3 is one measurement being used in the study. She wants to look at receptive and expressive communication, fine and gross motor skills, and risk of autism. To confirm that vigabatrin is safe as a preventive treatment for clinical seizures in infants with TSC. To confirm the feasibility of using EEG biomarkers to identify TSC infants at risk for developing epilepsy. And I look forward to the final results of Dr. Beban's project, and hopefully we will have some good evidence that being proactive in treatment of TSC is better than being reactive. The second study I want to highlight is being led by my colleague at the McGovern Medical School, Dr. Laura Farage. And Dr. Farage is working on modifier gene studies. And I'm hopeful that by studying modifier genes, we're able to someday offer personalized medicine in tuberous sclerosis. And what Dr. Farage is working on is developing a genetic risk prediction model for epilepsy in patients with TSC. So her first aim has already been met. She's already published a paper on an epilepsy risk prediction model based on known clinical and demographic risk factors for epilepsy and TSC. She's now working on a genetic risk score, and she's going to combine these two to have an even better risk prediction model. And I'm thinking that once we find out some of the modifiers that are in known epilepsy genes, that will help us in even being able to perhaps modify the ways we design treatment for patients with TSC who have seizures. And the last study I'd like to highlight is the STOP2 study, and this is led by Dr. Darcy Kruger at Cincinnati Children's Hospital. And Darcy Kruger's hypothesis is that early treatment with mTOR inhibitors before the onset of seizures can prevent the development of medically refractory epilepsy and closely linked deficits in neurodevelopment in the high-risk population of people who have TSC. And his primary aims are efficacy and safety, to demonstrate that sirolimus, an mTOR inhibitor, prevents or delays seizures in infants with TSC between 0 and 12 months of age, and that sirolimus can be safely used in this population. And his secondary aims are to demonstrate that sirolimus treatment in infants with TSC who are 0 to 12 months of age improves developmental delay, language impairment, adaptive skills, and autism risk by then testing them at 12 and 24 months of age after treatment, to assess the utility of EEG and MRI biomarkers for measuring mTORC1 inhibition in the brains of infants with TSC treated with sirolimus between 0 and 12 months, and finally, to validate precision dosing of sirolimus in infants with TSC treated between 0 and 12 months of age. So this is a slide I've used in many talks I've given, and in this slide it shows the trajectory of breakthroughs in TSC biology. And I've changed the top of the arrow to the date of 2031, 10 years from now, hoping that by then TSC can be detected at birth and treated prospectively to provide better outcomes in all who have this disease. Thank you. I'm ready for questions.